The information for the nutrition care process PowerPoint slide is found on chapters 2, 4, 7, and 10 in your Krause's Food and Nutrition Care Process textbook. You are expected to read those chapters and be well versed in the nutrition care process and the ADIME charting format before next week when you guys are in the hospital. Please take a minute to review this graphic. It's found on page 53, figure 4.1. And what are some of the concluding statements that you could draw from this graphic just by looking at it? Well, something that I drew from it was that the nutrient intake is influenced by many factors, including disease, socioeconomics, behavior, environment, physiological stress, many different things, and that can be compared to our nutrient requirements that we need, which are also influenced by many different factors such as growth, infection, psychological stress, things like that. And those two work together to get that optimal nutrition status that we see. So nutrition screening is the process in which the level of nutritional risk is determined to help to promote the optimal nutrition status that is at the center of this graphic presented on this slide. So some of the characteristics of nutrition screening, if you don't know them, those include weight history, weight status, need for nutrition support, presence of skin breakdown, poor dietary intake, access to food, and there could be other characteristics as well. So if you were doing a nutrition screening, what would be some of the risk factors? Well, some of those risk factors include, is this person on a restricted diet? Is their calorie or protein intake above or even below their recommendations? Maybe they have limited or low income, limited resources for the ability to prepare food, any abnormal laboratory values, and then also, are they on any medication? So is there drug-nutrient interactions and side effects that are maybe affecting their nutrient intake and their requirements? There are several nutrition screening tools available, or a facility might devise their own. Commonly used nutrition screening tools were evaluated by A&D with the results found in the Evidence Analysis Library. Based on these results, the following tools had the greatest validity and/or reliability. So the mini nutrition assessment is the short form, and that's found on page 57 if you wanted to flip to that. And this is a quick and reliable screening tool for subacute and ambulatory elderly populations. So you can even complete this short form on yourself just to kind of get practice as to how it would be done in a hospital setting. If you flip back to page 55, the malnutrition screening tool, which is found in box 4-1, this was the only one shown to be both valid and reliable for identifying nutrition problems in acute care and hospital-based ambulatory care settings. Another screening tool is found on table 4.2. And the nutrition risk screening is a screening tool that is used for medical, surgical, hospitalized patients, as it includes a grading of disease severity. This next slide shows the malnutrition universal screening tool in figure 4-3 in your book, which is found on page 55. This screening tool includes 3 independent criteria: current weight and height to determine BMI, weight loss score, and the effect of acute disease on dietary and nutrition intake for more than 5 days. And these 3 factors combined have a synergetic effect and provide a more complete view of nutritional status as maybe compared to those other nutrition screening tools on the previous slide. Based on the results of the screening process, individuals who are at a higher risk of malnutrition and who will most likely have a nutrition diagnosis indicative of a full nutrition assessment and intervention. So those deemed at nutritional risk, that's when we would move on to the nutrition care process. So what can you tell me about the NCP? I'm sure that there's a lot that we have all heard about the nutrition care process, but for a more complete or concrete understanding and definition, the NCP is a process for identifying, planning for, and meeting the nutritional needs of a given individual. Additionally, the NCP established a more standardized method of assessing nutritional status, diagnosing the nutritional problems, and drafting intervention plan to promote improved nutritional status. Each step of the NCP has corresponding terminology that allows for standardized documentation in the EMR. This terminology is referred to the International Dietetics and Nutrition Terminology, or more currently called the NCP terminology. Nutrition assessment is the first component of the nutrition care process, and this is a systematic process of gathering adequate information in which to make a professional judgment about the nutritional status of an individual. The data gathered in this type will guide the remaining steps. And encompassing the nutrition assessment, there are 5 components of this assessment. The first one is food and nutrition-related history. The food and nutrition-related history examines the individual's food and nutrient intake and administration. And we can determine this with many different methods. So we could utilize a 24-hour recall if they are able to remember the last 24 hours and what they took in. You could ask them about their typical day's intake. We could utilize a food frequency questionnaire, which if you turn to page 61 in your text, an example of that is found in box 4-3. We could also determine their food and nutrient intake with the use of apps. So if they have a certain app on their phone or computer, we could determine their daily intake. Diet history, that's presented on page 60 in box 4.2. A subjective global assessment, mini nutrition assessment long form, which if you flip back to page 57, the long form is also presented there, or talked about. We could also ask them if they have a food diary. So on page 61, there's an example of that in figure 4-6. And then if you want to flip to page 62, I know we're doing a lot of flipping here, but table 4.4 provides advantages and disadvantages of several of the more commonly used tools. So that's something that we should consider when we're picking which tool we're going to utilize. Additionally, within the food and nutrition related history, it also examines medications and complementary alternative medicine use. So these may impact nutritional status, and if you read chapter 8, that focuses on the food and drug interactions if you wanted to get a more better understanding of that. Food and nutrition knowledge, attitudes, and behaviors, that's another important component of the nutrition related history, because we need to know how they feel about food and maybe certain beliefs that they have towards foods that they don't eat. Nutrition related behaviors, and then also factors affecting their access to food. So is there financial issues that are impacting their access to food, or maybe they don't have the proper transportation to go and even buy that food. And then also oral health has affects their access to food, because if they can't if they can't eat properly or maybe they can't taste properly, that's going to definitely affect their access. Physical activity and function is another component, and then also nutrition-related measures that impact the individual's quality of life. So that's all part of the food and nutrition-related history component of nutrition assessment. The next section is the anthropometric measurements. Anthropometry involves obtaining physical measurements of an individual, comparing them to standards that reflect the growth and development of that individual, and using them to determine nutritional status. So commonly used anthropometric measures for adults that would include height, weight, skin fold thickness, circumference measurements such as at their waist or maybe mid-arm. And then Chapter 7 provides additional information on taking those anthropometric measurements if you wanted to go and look at those, which I would advise you to do so. This next slide focuses on equations that are used for adult anthropometric measures. So calculating the ideal body weight, we use the above equation, and then percent ideal body weight can be helpful as well if we want to determine that. So for males, it's the equation up above, and then females is a little bit different to determine ideal body weight. From the height and weight alone, the BMI can be calculated, but there are some limitations of the BMI. So BMI doesn't really take into account the difference between fat mass and lean mass. It's just weight in general. So that could obviously yield a false BMI result. And then it's also important to consider the differences in race, sex, and age when determining and looking at someone's BMI as well. Overall, body composition measurements factor in fat mass, soft tissue body mass, and bone mass. So for example, older adults tend to have lower bone density and reduced lean body mass, and therefore they actually may weigh less than younger adults of the same height and yet have greater adiposity. Variances for different population groups need to be factored in as well. Body composition can be determined through the use of skin fold thickness measures and circumference measurements. An individual's current weight status is important, but we also need to know their weight history to determine that weight loss or gain that they may be experiencing. So according to the Aspen and A&D benchmarks for evaluating weight loss, we can use the above table, which determines if the individual is having significant weight loss or severe weight loss. So you can just see the percents and then also the length of time in which you would see that loss. And we look at this a lot when we talk about malnutrition in the later weeks at the hospital. You can also utilize, in addition to this, usual body weight and percent usual body weight to help determine that weight loss or weight gain that you're seeing. And a lot of times it's very useful to put that usual body weight and percent usual body weight in the ADIME note just so you can determine that weight loss or weight gain. So that was for the adult anthropometric measures, but for children and pediatrics, anthropometric measures are taken a little bit differently. So in children, head circumference and lengths are used in addition to weight. The growth charts are presented in appendices 4-11 in your text, which you guys might want to look over. And the classification of BMI for age percentiles are found in box 7-2 on page 112. If you wanted to flip to that right now, just have a quick look over. So let's test our knowledge of proper measuring of children. If you look at the above picture and the above scenario, is the measurement of this child's weight appropriate or inappropriate? So this measurement of weight is actually inappropriate because the child is wearing too many clothes and the weight will be too heavy with those clothes on. This next slide is another scenario, but this time we're looking at height. So would this measurement be inappropriate or appropriate? This is another inappropriate anthropometric measure for pediatrics because this child's body is not vertical. And then also the stature should be measured without shoes because a false height would be given. So this anthropometric measure is looking for length measurement. Would this be inappropriate or appropriate? This is actually another inappropriate way to measure length because the measurer has extended only one leg of the infant, and this will indicate that the measurement will actually be short. So both legs should be used to measure length. So those are just some differences between how we examine adult anthropometric measurements and then how we would examine pediatric anthropometric measurements. So the next component of the nutrition assessment would include biochemical data, medical tests, and procedures. So you probably know some examples of biochemical data, but pretty much that's the laboratory test and those values that we get maybe from blood work, things along those lines would fall under the biochemical data. So laboratory data are the only true objective data used in nutrition assessment. Laboratory-based nutrition testing can be used to estimate nutrient content in the body, which can be helpful in both the treatment and prevention of disease. So it's really important that we're looking at those laboratory values. For more information on the various laboratory tests, tables 7-1, 7-2, and 7-3 on pages 100 through 102 highlight those various lab tests that are commonly run for nutritional purposes. And those are really important to look over because as we're going to be in the hospital, it's really important that we are including laboratory tests that are pertinent to someone's nutritional status only, and those are lab values that we can change through nutrition. So we need to make sure we can highlight the ones that have that nutritional impact and those that do not. However, when you are reviewing the lab values, you must also factor in the individual's hydration status, and this is because if an individual is dehydrated, then the solutes will be more concentrated versus if they're overhydrated, the solutes will be diluted. So hydration status has a lot to do with their biochemical laboratory values as well. So it's something just to look at. I by no means have covered all the information in chapter 7, so you'll definitely need to look back and read or reread that chapter so you can get all the information that is presented. The next component is the nutrition-focused physical findings. The nutrition-focused physical exam include the findings from an evaluation of body systems, muscle and subcutaneous fat wasting, oral health such as swallowing and breathing ability, and then appetite and effect. So in week 3, we will learn more about this and how to interpret the findings, and then also there will be probably videos posted about how we are to do the nutrition-focused physical exam. And we will be performing those in the hospital as well, so it's very important that we understand what we need to be looking for that complete nutrition assessment. The final component of the nutritional assessment is the client's history. And this history could be personal history, which includes age, gender, race, what language they speak, what's their education level, and also the role in their family. That's another important one to consider. Previous medical history would also be included, and that also encompasses family medical history. So we need to include both personal and then the family medical history as well. And lastly, social history should be included in nutrition assessment, and that includes housing, access to medical care, involvement in social groups, and then their socioeconomic status. And we've kind of touched base on how those can all affect our nutrient intake in the previous slides. And the client history really allows us to learn a lot more about our client as well. All right, so estimating energy needs. So based on the findings from the nutrition assessment, you will need to calculate the energy, macronutrient, and or the fluid needs of your individual. Needs will be based on disease states and the degree of depletion, so that's something to keep in mind. There are several methods for estimating energy needs, such as from current energy intake, the Institute of Medicine, and the use of Mifflin-St. Jean formulas. So the Institute of Medicine is found on pages 23 and 24 in box 2-1 and table 2-2. And really, the one highlighted here is the Mifflin-St. Jean, and I would say that's probably one of the most widely used ones. And those equations are, take note that they're different for males and females, and then weights in kilograms, height in centimeters, and age in years when you're calculating that. So determining total energy expenditure, or TEE, that is your estimated energy requirement plus the thermic effect of food calories, and then plus physical activity. So encompasses quite a bit. The thermic effect of food is estimated at about 10% of kcals consumed, and physical activity increases REE by the percent as highlighted on the slides. So it can range from a small 10% to quite a bit at 60%. Additionally, macronutrient and fluid needs will be discussed in further weeks to come. So after the nutrition assessment, we move on to nutrition diagnosis. And this phase results in the development of a PES statement, which concentrates on the nutrition-related problems which can be either improved or resolved by implementing an appropriate nutrition care plan. And there's three components of a nutrition diagnosis, or three kind of categories your PES statement can fall under. So the intake component of the nutrition diagnosis includes the assessment of nutrient and calorie intake and the determination of what to do about it. The clinical component includes nutritional findings or problems identified as related to medical or physical conditions. And then the behavioral or environmental components include identified findings or problems that are related to maybe their knowledge, attitude, and beliefs, their physical environment, access to food, water or nutrition-related supplies, and food safety. The PES statement. So the nutrition problem, it's the nutrition problem related to the etiology as evidenced by the signs and symptoms. So the problem refers to the patient's altered nutrition status or the problem as determined by the nutritional assessment. So we're looking back at what we did and determining a problem from that. Etiology refers to the cause or contributing factors of the patient's nutritional problem. So what's causing this patient to have the problem that we just mentioned. And then signs and symptoms are derived from the subjective and objective information that documents or supports a nutritional problem. So that's kind of like our evidence as to why this is a problem. If you want some sample PES statements, they're found on page 166, just to kind of get a feel for how that PES statement flows. So when making a PES statement, this is just a quick checklist as to if this statement is essentially good, and is it pertinent to the client, and can it be really fixed with nutrition. So if the NCP cannot influence the problem, then it isn't a nutrition problem. You want to select the most acute or severe problem that can be nutritionally impacted, and then document that there are no nutritional problems at this point in time. So if there is no nutritional problem identified, make sure you state that. However, if there is, make sure you're selecting the most acute or severe problem that can be nutritionally impacted, and we can make a PES statement from it and make the rest of that intervention and monitoring. Alright, so following the nutrition diagnosis, we now have the nutrition intervention, and the final product of the nutrition intervention phase is the development and implementation of the care plan. So the 4 categories of nutrition interventions include food and or nutrient delivery. So the nutrition prescription is written by the registered dietitian nutritionist and designates the type, amount, and frequency of nutrition based on the individual's disease process and disease management goals. A nutrition prescription is different than a diet order, as only a licensed independent healthcare provider, such as the doctor, can enter in diet orders. Additionally, another category is nutrition education and or counseling, so maybe they just need some information presented to them. And then coordination of nutrition care, such as a referral to a food assistance program or a speech pathology for a swallow consult, because we cannot perform those. With each intervention, a goal needs to be identified so that the RDN can determine if the intervention was successful. If we don't have a goal, we can't determine if it's successful, obviously. And whenever possible, the nutrition intervention should target the etiology identified during the assessment step. So really, we're catering to the cause of that problem. Also importantly, the interventions need to be specific and patient-centered goals. So if you want to flip to page 162 in your textbook. Box 10.1 is an example of an application of the NCP to a patient. So if you wanted to look over that and just see how that example is given, that would be very beneficial. So the final phase of the nutrition care process is the nutrition monitoring and evaluation. So following our intervention and the goals that we set, we're going to monitor and evaluate our care plan. So this is when the RDN determines if the treatment or interventions are working and if the established goals have been achieved. The monitoring refers to the review of the patient's nutrition progress at scheduled reassessment times. So whenever we're back and we're with our client, we're monitoring them during that time. And the evaluation piece is the comparison of the current nutrition parameters to the previous findings that we had earlier. So in this phase, the RDN will determine what the pre-planned follow-up measures will be. So for example, what lab values might be monitored on a daily basis, and then also maybe looking up the tolerance to a new diet order. So that's part of the monitoring and evaluation step, or the last step in the nutrition care process. Lastly, we're going to talk about documentation. M&T and other nutrition care must be documented in the electronic medical record, or it didn't happen. So if we don't document it, there's no proof that it happened, so it really needs to be documented. And the EMR is a legal document, so documentation ensures that that the nutrition care is relevant, thorough, and effective, and it allows the entire healthcare team to understand the rationale for the proposed nutritional care. Therefore, the EMR serves as a tool for communication among the members of the healthcare team. So it's, again, really important to document and do correct documentation. SOAP notes, they're found on page 164, and then ADIME notes. These are two kind of documentation tools. The ADIME is found on page 165, and those are the two most commonly used formats within the problem-oriented medical records. So that concludes our presentation on the nutrition care process. Hopefully that was all a review to you guys. But please be sure to read or reread the chapters thoroughly that were highlighted in this PowerPoint. And then please reach out if you have any questions regarding the nutrition care process.